Okay, welcome once again to this lecture, Drugs for Heart Failure. And we'll start today's lecture with the questions that were asked yesterday. One question was from Dr. Aziz, who is my friend, and he asked about the sensitivity and specificity of this test, NT-proBNP, right? We have two BNP and NT-proBNP. NT-proBNP has a longer half-life, and that is more commonly used, that is more reliable. Okay, so I checked many sources, but this one, I've given the reference down here. The sensitivity is 91.4%, and the specificity is 91.5%, which is pretty good, right? That is a very good test. In some other sources, the figures were a little bit different, but we will take this as correct. All right, so this means it is good. And we have the negative predictive value and the positive predictive value, which means, for example, the positive predictive value means that if the test is positive, what is the probability that the patient will have the disease or the patient has the disease, right? And it depends upon the prevalence of the disease as well. So that was the answer to the first question. And then we had another question from someone, I don't know whether he's here or not, which was this. Yes, can you explain please how in diastolic heart failure ejection fraction is not changed? So I took 2 or 3 slides from my pathophysiology lecture, and we will just discuss in 3 or 4 slides this point. Okay, so systolic versus diastolic heart failure. So systolic ventricular dysfunction. It is a dysfunction of systole. It is a dysfunction of the contraction of the heart. Most heart failure is the consequence of systolic dysfunction. Myocardial contractility is impaired, leading to decrease in ejection fraction. This is most commonly due to ischemic heart disease or hypertension or myocardial infarction or any other disease of the heart, which is known as cardiomyopathy. And then we have got diastolic ventricular dysfunction. It is characterized by a normal ejection fraction. So that is what the gentleman was asking, how a normal ejection fraction could lead to decreased cardiac output, and I'll show you in the next slide. But impaired ventricular relaxation leading to decrease in ventricular filling. So the preload is low. Preload, in other words, is the venous return or the end diastolic volume. Stroke volume is low and cardiac output is low. And it's like this, as if someone is holding the heart and it's compressing, not letting it expand, not letting it dilate, right? That is what diastolic heart failure is. In 55% of cases, systolic function is preserved, and heart failure is because of diastolic dysfunction, or at least there is some component of this diastolic dysfunction in heart failure, right? Although, as we said, systolic heart failure is more common. Relaxation is abnormal and contraction is normal. There is inadequate filling of the heart, which leads to a decrease in cardiac output, and that would lead to all the signs and symptoms of heart failure, right? Now, the prevalence of diastolic heart failure is higher in, as I said, I mentioned women yesterday, but in old age, in hypertension, in atrial fibrillation, all of these are the causes of diastolic dysfunction, and I'm going to show you one more slide. So causes of diastolic dysfunction, which are delay in expansion, and that happens in pericardial effusion, which I've shown you in this small little figure. If you see it, this one, there is fluid around the heart, so that will compress the heart and it will not let the heart fill properly in diastole. Constrictive pericarditis is another cause which happens in certain diseases like in tuberculosis of the heart. Increased wall thickness, myocardial hypertrophy, and hypertrophic cardiomyopathy. Now, what you see over here, this is the normal heart, and you see the chamber size. It is so big, the cavity is pretty big, whereas because of muscle hypertrophy over here, there's just no space inside the heart, right? And that is why the cardiac filling is impaired. Delay in relaxation most commonly happens in aging and ischemic heart disease, right? So that was a quick explanation of the causes of diastolic dysfunction. Now we'll go to ejection fraction. In one slide, I'll explain to you what ejection fraction is and what is the difference between stroke volume and ejection fraction. So ejection fraction is the percentage of blood pumped out of the ventricles in each heartbeat, right? So that is the stroke volume divided by end diastolic volume. If now I've got a question for you. See, if the end diastolic volume is 150 ml and ventricle pumps out 100 ml of blood with a beat, you know, the amount of blood that is pumped out is known as stroke volume. So what is the stroke volume in this case? All right, I'm waiting for an answer. So I'll answer this for you. As I said, stroke volume is the volume of blood pumped out of the heart, the ventricles in one beat. So it says each ventricle pumps out 100 ml of blood. So obviously this is the stroke volume. 100 ml is the stroke volume. But if I ask you to calculate the ejection fraction from diastolic volume and stroke volume, what you will do is you will divide a stroke volume 100 by 150 and then take a percentage, multiply it by 100. So it is 66.7%, which is normal. I said that 55 to 70% is normal. So stroke volume is a volume and ejection fraction is a percentage, right? And this is what the normal ejection fraction is. Now I will quickly calculate for you the stroke volume or the ejection fraction in diastolic heart failure. If the end diastolic volume is 120 ml and the heart rate is 70 per minute. Now I've given a little higher figure over here. Normal ejection fraction is about 100 ml on the average. Normal end diastolic volume is about 100 ml, but let's say it's 120 ml and the stroke volume is 70 ml. Then if we calculate the ejection fraction, it will be 70 divided by 120 into 100, which is 58.4. All right, now let us suppose, and the cardiac output is 4.9 liters because cardiac output is heart rate multiplied by stroke volume. All right, so I hope you remember this thing from your physiology. Now let us suppose that the patient has got diastolic dysfunction and the filling of the heart is impaired, all right? Let us suppose that in that case where the heart is not filling properly or fully, the end diastolic volume is 80 ml, the heart rate is same as over here, 70 per minute, and the stroke volume is 47 ml. All right, so if you calculate the ejection fraction, it is 47 divided by 80 into 100, 58.8%. Now you see the ejection fraction is preserved. Here it is 58.4 and here it is more than 58.4, it's 58.8. But if you calculate the cardiac output, it is 47 into 70 now, 3.3 liters. As opposed to 4.9 liters over here. So cardiac output is down, and you know that heart failure is a syndrome of low cardiac output, which has got certain clinical manifestations that we saw previously, right? And this is the question that we have already seen yesterday. So I will just go through it. The correct answer over here is some people made a mistake because I am asking for a chronic condition, but some people picked up acute conditions. So acute is right away out because I'm asking for chronic conditions. So A and E are out. Hepatomegaly, obviously this will happen when there is right heart failure, not in the left heart failure. So pulmonary hypertension is the best answer in this case. And as I said, that hepatomegaly will be there when the pressure goes down from the right ventricle, right atrium down to the liver, and then the JVP will also be raised in that case, all right? So let's see whether you can answer this or not. I showed you the New York class 3. I'm asking about New York Heart Association class 3 heart failure, right? So please read this quickly and let me know what is the correct answer. All right, so I'll give you a hint. I have one answer over here which says C, and let me give you a hint, all right? And the hint is, well, there is no complaints, physical activity without much difficulty, breathlessness at rest, and these are some clues. And here is the table which I showed you yesterday. All right, I got a couple of answers which say D, and D is the correct answer. Because in the first three cases, class 1, class 2, class 3, we said that the patient is comfortable at rest, right? And class 4 is the signs and symptoms of cardiac insufficiency are present at rest. So here the patient is comfortable. Here he can do physical activity without much difficulty, which means that it is class 2, it is slight limitation. There are no complaints over here, that must be class 1, no symptom. And this is class 4 because at rest he has got the symptoms of cardiac insufficiency. So the correct answer in this case is D, all right? Now, that's just a cartoon, all right? There are going to be 200 USMLE type farm MCQs on the next test. If you say that to a medical student, obviously his heart is going to be stressed and he will get tachycardia and whatnot. All right, now we go on to the drugs, drugs used in the treatment of heart failure. And once again, I'll remind you of the compensatory mechanisms. It is the compensatory mechanisms that are sometimes harmful. Frank-Starling mechanism is good for the heart, but unfortunately, when there is heart failure, the capabilities of the heart are beyond the limits of Frank-Starling mechanism, which means that Frank-Starling mechanism cannot work in heart failure to its full extent. Maybe it is working a little bit, but it is not working sufficiently or enough to have a normal cardiac output. Sympathetic nervous system, as I said, let us suppose that there is a patient who is ill with COVID infection, right? We are having this COVID these days. You will not ask that patient to run in the corridors of your hospital. You will give him a bed rest. But when the heart is ill, the sympathetic nervous system asks the heart to run faster. It increases the heart rate, and that is one of the signs of heart failure, right? Tachycardia or increased heart rate. Renin-angiotensin aldosterone system, it increases the fluid volume, intravascular fluid volume, so that's not good for the heart. Natriuretic peptides are good for the heart. Endothelins are not good. They cause vasoconstriction. Inflammatory mediators are sort of biomarkers. We use that as one of the diagnostic parameters. And myocardial hypertrophy is also not good, fibrosis and dilatation. So what we do in the treatment of heart failure is that we address all of these harmful or detrimental compensatory mechanism, and we try to correct them or counter them to whatever extent is possible, right? Now, here is the drug list. We have got ACE inhibitors, captopril, enalapril, fosinopril, lisinopril, quinapril, and ramipril. We have got ARBs, angiotensin receptor blockers. We call them the sartans. These are known as the prils. We have got many of them. I'll show them. We have got beta blockers, bisoprolol, metoprolol, carvedilol, the most commonly used these days. I read somewhere that nebivolol and penbutalol could also be used, but these three are the established ones. Okay, we have got diuretics, loop diuretics, and thiazide diuretics. This one is important because it works at a very low GFR. If a patient has got chronic kidney disease with heart failure, which is not surprising, then these diuretics like furosemide and hydrochlorothiazide, once the GFR is below 30 ml, which is stage 4 chronic kidney disease, then these don't work. So metolazone works even at 20 ml of GFR, right? Then we have got vasodilators, nitrates, and we have got hydralazine. We will come to that later on. Inotropic agents, digoxin, dobutamine, enamrenone, and milrinone. And these two are phosphodiesterase inhibitors. We'll show you these things later on. We have got aldosterone antagonist, eplerenone, spironolactone. This is a newer drug, angiotensin receptor neprilysin inhibitor. And we have got ivabradine and SGLT2 inhibitors, which were basically used for type 2 diabetes, but they proved to be working very well in heart failure. They reduced hospitalizations in heart failure, chronic heart failure patients. So they have sort of been reclassified from diabetic drugs to cardiac drugs, okay? Of course, we have got one more drug that I've not mentioned, but it will be here. And this is an update, say 6 to 7 months old. And as I said in the beginning, the therapeutic trends have changed a little bit, right? Now we have got ARNIs, actually I mentioned it in the previous slide, which is angiotensin receptor neprilysin inhibitor, beta blockers, mineralocorticoid receptor antagonists, which are spironolactone and eplerenone, and SGLT2 inhibitors that we will come to in a minute, empagliflozin and dapagliflozin, we call them gliflozins, all right. In case a patient cannot tolerate ARNIs, he can use ACE inhibitors and ARBs. Previously, we used to start with ARBs and ACE inhibitors, basically ACE inhibitors and diuretics, right? Now you see this change, ACE inhibitors have been replaced by ARNIs. We have got this mineralocorticoid receptor antagonist at an earlier stage. SGLT2 inhibitor has become the first line drug. So quite a bit of change over there. So this HFrEF with reduced ejection fraction, the heart failure, we have to individualize the therapies. Now, in general, the 4 foundational drug classes that what we call now are ARNIs, beta blockers, and mineralocorticoid receptor antagonist, and sodium glucose transporter inhibitors. They work in the proximal tubules of the kidneys, and this is angiotensin receptor neprilysin inhibitor, right? And depending upon the condition of individual evaluation of the patient, we can use many other drugs. And here again, I'm showing you some new drugs. Ivabradine is a relatively new drug. It was approved about 4 years ago. Digoxin is a good old drug. Hydralazine and isosorbide dinitrate, they have been in use for quite a long time. Omecamtiv mecarbil, this is a new drug, and we will have a look at this one. Vericiguat is a new drug. Okay, all these drugs have been approved. I mean, these 2 drugs have been approved in the last 2 years. Okay, and then intravenous iron, most of the times we overlook this thing. Iron deficiency is a major heart failure comorbidity present in about 50% of the cases with stable heart disease. So when we are treating heart failure, because heart failure is a chronic disease, and this is anemia of chronic disease. All right, I've given you the causes over here. But basically, this is anemia of chronic disease. There's an element of inflammation, which is preventing the proper use of iron or the absorption of iron, all right? So now these slides, I'm not going to go into the details, but this is giving, because it's not a therapeutics lecture, but it is this, and this is patient profiling. We are looking at BPM and heart rate and blood pressure and atrial fibrillation and chronic kidney disease, hyperkalemia. That's what this did. We are combining all the patients' signs and symptoms or comorbidities, right? And when the patient has a combination of these for different combinations, we have got different therapies, all right? So this slide will be there when you look at the recording. You can stop and have a look over here, or I can even give you the handout if you want, all right? So we'll just go through this because basically what we are doing in this lecture is pharmacology of heart failure drugs. Now, some evidence supporting the pharmacologic treatment of heart failure with reduced ejection fraction, and this is based on randomized controlled trials, and that is what we call evidence. You know, I don't know whether you are familiar with what evidence is. We have got what we call evidence is basically these clinical trials, and there are certain conditions for the clinical trials. Sample size is very important. These days, the clinical trials are having thousands of patients. Number two, they should be controlled, very important. They should be blinded, very important. And then we have got meta-analyses. That is another evidence that we get from a lot of papers. We don't actually do a clinical trial, but we try to obtain evidence from a lot of different reliable sources. Okay, so that is known as meta-analysis or systematic reviews. So this is what is meant by evidence, and our treatment these days are mostly based on evidences. Okay, so ACE inhibitors, ARBs, you know, all patients with prior or current symptoms of chronic heart failure. But as I said that recently we have introduced these ARNIs and SGLT2 inhibitors. So they have gone a little bit to the back burners, okay? Beta blockers are still very much in. ARNIs are the new sort of trend or paradigm, and mineralocorticoid receptors, which are eplerenone and spironolactone, they are also there because these basically what they do is they prevent cardiac remodeling. Cardiac remodeling is a big problem in chronic heart failure, and that is irreversible if you don't stop that, okay? So the goals of therapy is obviously to control the risk factors, which is hypertension, obesity, and diabetes. I hope that is not a surprise for you, and eliminate or minimize symptoms. So we do symptomatic treatment as well. We try to slow. Now this heart failure, you know, it goes for a long time. You might say that it is a progressive disease, which means you cannot stop it, but you can slow it down, right? If you give proper therapy, and if you make a timely intervention, you can slow it down drastically, and it will go on for years and years and even decades. Patients live for 20 to 25 years or maybe even more with heart failures, okay? And you have to improve survival. So pharmacological intervention, reduction of load on myocardium, decrease fluid volume. We use diuretics for that, and ACE inhibitors do that to some extent. We improve contractility, right? And we slow the rate of remodeling through some drugs, okay? And I mentioned that these eplerenone and spironolactone mineralocorticoid receptor antagonists are good for that, okay? Now, this is therapy based on the different classes of New York Heart Association. I'll come back to this initial therapy in one of the slides later on as well, but this is just a repetition of what I've already said. ARNIs and ARBs and beta blockers and SGLT2 inhibitors, right? And New York Heart Association class 2 to 4 with symptoms of volume overload. Now, because this is not a clinical lecture, but I would remind you of Forrester's classifications, Forrester's subsets. The Forrester has 4 subsets, which depends upon this volume overload and perfusion of the tissues. We will discuss that some other time. But in case of volume overload, you have to give diuretics, okay? And then Persistent loop diuretics, we have got thiazide diuretics and we have got loop diuretics. Loop diuretics, with them, you have to be a little bit careful because they could lead to dehydration as well. Persistent symptomatic African Americans, they are a little bit different. They don't respond very well to beta blockers, okay? And even the elderly, they don't respond well to beta blockers. So add hydralazine and isosorbide dinitrate. These are vasodilators. And I'll come back to this, but I mentioned endothelines in the compensatory mechanisms, which are vasoconstrictors, right? So there you have got some treatment to address that. Okay, let me see, there is something on the chat. Why do we prefer loop over thiazide diuretics in heart failure? Well, the use of loop and thiazide diuretics depends more upon the extent of edema, the seriousness or the severity of edema, right? That is one thing. For example, pulmonary edema, you immediately give 80 milligram of Lasix, which is furosemide. You can give, start off with an infusion as well, right? That is the most severe condition. The second thing is chronic kidney disease, right? As I said, thiazide diuretics do not work very well when the GFR goes below 50 or 45 milliliter per minute, okay? So these loop diuretics will work up to a GFR of 30 ml, whereas thiazide diuretics do not work very well when the GFR is less than 45 ml. All right, so maybe that is one of the reasons, okay? Right. Then let me see. All right. So add aldosterone antagonist, but these days, this is a little bit old one. If the creatinine clearance is 30 ml and potassium is less than 5 milliequivalents, then we add aldosterone antagonist, right? Remember, aldosterone decreases potassium levels, so aldosterone antagonist can lead to hyperkalemia, which we try to avoid in heart failure. We monitor potassium all the time, okay? So this is just a general overview of the drugs. And now this is what I was referring to in a couple of slides previously. HFrEF, when the left ventricular ejection fraction is less than 40%, which is the definition of HFrEF, then we initiate the therapy with the ARNIs or ACE inhibitors and beta blockers and mineralocorticoid receptor antagonist and SGLT2 inhibitors. Right now, they are, recommending to start the therapy with multiple drugs. Okay, but this is a clinical decision, and I would say that a cardiologist is the ultimate person to decide which ones to start with. Okay, right. The rest, it is just clinical assessment factors. This is just a simple algorithm, reassess left ventricular ejection fraction. So I'll just skip through this. You can have a look at this slide yourself, and I'll go to the drugs. And so the first group of drugs are these prils, ACE inhibitors. Okay, we have got enalapril, we have got fosinopril, we have got captopril, we have got lisinopril, we have got quinapril, we have got a combination of quinapril with hydrochlorothiazide, and we have got ramipril, and again a combination with a diuretic. Okay, now ACE inhibitors. So now we are addressing this part of the compensatory mechanism, the renin, angiotensin, aldosterone system. Okay, that is not good for the heart. So angiotensin 1 is converted to angiotensin 2 in the lungs and some other places in the body, endothelial cells, or maybe some in the kidneys as well. Now ACE inhibitors are going to block the reaction over here. Now angiotensin 2, we don't want angiotensin 2. We don't want angiotensin 2 in hypertension, we don't want angiotensin 2 in heart failure, because angiotensin 2 has got a lot of effects like aldosterone secretion, not good for the heart, sodium reabsorption, potassium excretion, and water retention, not good for heart. I mean, the failing heart. Increased sympathetic activity, not good. Vasoconstriction, increased blood pressure, not good. And increased antidiuretic hormone secretion, which will lead to this plasma volume expansion, again, not good for the heart. And angiotensin has another effect that I've not mentioned, which is cardiac fibrosis, okay? So what ACE inhibitors do, they block the reaction over here. So all these downstream effects will not be there. But unfortunately, this enzyme also breaks down bradykinin, okay? So bradykinin will not be broken down. And I mean, I'm showing you the normal one. If this enzyme is working, then we will have a lower level of bradykinins. But when we block this through the ACE inhibitor, then the bradykinin level will be high, which is good for blood pressure because bradykinin causes vasodilation. But the side effect is that it causes dry cough in 30% of cases that are taking ACE inhibitors, all right? So this is just a graph that I'm going to show you over here compared with placebo. The clinical trials have shown that enalapril reduces the cumulative mortality in heart failure patients, all right? So the effects on heart of ACE inhibitors is decrease in blood pressure, decrease in preload, decrease in afterload, increase in cardiac output, morbidity, mortality, arrhythmias, infarction, stroke, all these are reduced, all right? All right, so indications recommended in all stages of reduced ejection fraction in combination with beta blockers, but keep in mind that now we have got ARNIs as well, and now we have got SGLT2 inhibitors. Recommended in all stages of HFpEF as well. Okay, so both, we said that whereas HFrEF has got very good therapies, we don't have very effective or efficacious therapies for the heart failure with preserved ejection fraction. So the greatest benefit is in reduced ejection fraction, and they're also beneficial in myocardial infarction, all right? Absorption is good. Food decreases absorption, so you have to take them on empty stomach. They're all prodrugs, which means they have to be converted to active metabolites when, I mean, they are converted to active metabolites when they go into the body and they undergo metabolism. Renal excretion, that means we have to be careful except for fosinopril. In renal insufficiency, we have to be careful. We have to reduce the dose, and we have to monitor the therapeutic effects, all right? Half-life is 12 to 24 hours, and ramipril and fosinopril have got a once daily dosing, all right? So these things are important to know, at least in pharmacology, because we need these things when we treat the patients, okay? Right, adverse effects, again, you know, we have to know a little bit of adverse effects. Now this man is about to fall down, looks like he's dancing, but actually he has postural hypotension. Any drug that reduces the fluid volume and any drug that causes vasodilation can cause postural hypotension, all right? Renal insufficiency because it reduces GFR. Right now, why it reduces GFR, I don't know whether you know that or not, but I've got the explanation in another lecture. Maybe we'll come to that later on when we do. I'm not sure where I have it, but I'll just briefly tell you, you know, angiotensin 2, now listen carefully, angiotensin 2 causes constriction of efferent arterioles in the glomerulus, right? Vasoconstriction in the efferent arterioles. When there is vasoconstriction in the efferent arterioles, the pressure will increase in the glomeruli and the GFR will increase. Okay. Now, what happens is that when you block angiotensin, That vasoconstriction in the efferent arterioles will not be there. The pressure in the glomerulus will decrease and the GFR will go down. But if you don't get that, I'll explain that to you later on with the help of a figure, all right? You can get hyperkalemia because the GFR is low. You can get dry cough, angioedema. This is what angioedema is. It could be serious, there could be swelling of the larynx that could interfere with breathing. So it could potentially be fatal. Look at the tongue, pretty gross swelling of the tongue. And they are pregnancy category C and category D, all right? Right. So now we go on to the next category of the drugs, which are known as sartans. So we have got losartan. This is amlodipine is a calcium channel blocker. So this is a good combination for hypertension, I would say. And valsartan is there. We have got valsartan plus a thiazide diuretic combination. Candesartan is there. Again, a combination with hydrochlorothiazide. We have got telmisartan, and we have got a combination with hydrochlorothiazide. So this means most of these drugs are meant for hypertension and for heart failure as well. But let me remind you, I would say that you should give a diuretic only when you find evidence of fluid overload, which is there in most of the cases. Because let me remind you, one very rare but very dangerous side effect of these thiazide diuretics, and that is interstitial nephritis, right? It damages the kidneys. It does happen in some people. Right, so angiotensin receptor blockers, we have got candesartan, we have got losartan. I showed you all these things. Now, here is the mechanism of action. Angiotensinogen is converted to angiotensin 1 by renin, then angiotensin 2 by ACE, angiotensin converting enzyme, and angiotensin 2 affects angiotensin 1 receptor. We have got more than 2 types of receptors, but angiotensin 1 receptors are clinically most important, and perhaps these are the receptors to which they said that this COVID virus binds, okay? Anyway, if I'm wrong, please correct me. So these drugs are mostly blocking angiotensin 1 receptor. These angiotensin 2 receptors are mostly found in early life, in fetal stage, right? So they block here, and all these effects of angiotensin, these effects will be dampened, they will be. No drug completely eliminates the effects of the receptors, but what it does is it reduces the activity of the receptors, all right? So ARBs will stop all these actions of angiotensin 2, and these drugs are orally active. They are competitive antagonists, okay? More complete blockade of AT1 receptor, no effects on bradykinin levels. So that is why we do not get dry cough over here. Substitute for ACE inhibitors if patient cannot tolerate them, but it depends upon the physician. Many physicians, they start with ARBs. Others would prefer to start with ACE inhibitors. So that is a clinical decision. Effects on cardiovascular system used for treatment of hypertension and treatment of heart failure, right? Pharmacokinetics and adverse effects. Losartan has extensive first part metabolism, and many of its metabolites are active. Other drugs in this group have inactive metabolites. Elimination is urine and feces, which means some of it is excreted by the liver as well. It is highly protein bound is candesartan. When a drug is highly protein bound, that means those patients who have low albumin level, for example, the patients with cirrhosis of liver because albumin is synthesized in the liver, or those patients with nephrotic syndrome who are losing a lot of proteins through the kidneys, you have to be careful in those patients, okay? Adverse effects are similar to ACE inhibitors, except that they do not have the dry cough. Pregnancy category D, which means there is evidence of damage to the fetus, but we have to balance or weigh the harms against the benefits, okay? Myocardial infarction, well, this is controversial. We do not have some solid evidence for that. And the next, we go to beta blockers, all right? So we have carvedilol, we have got metoprolol, which comes as tablets, so oral. This is also tablets. We have got injection as well. So the route of administration is both oral and IV. We have got bisoprolol, again, tablets. We get a combination. We get that without a combination as well. Again, this is one of the brands for bisoprolol. And effects of chronic activation of sympathetic nervous system. Now, what we said was that one of the effects, one of the, say, detrimental effects of heart failure was activation of the sympathetic nervous system, right? Increased heart rate is there in heart failure, but that is not good for a failing heart. Okay, it increases the workload on the heart. So this is what it's showing, increase renin. Can someone tell me why would renin be increased in sympathetic stimulation? Why would there be increase of renin when the sympathetic nervous system is overactivated or activated, whatever you want to call? Any ideas? All right, I'll give you the answer. The granular cells of the afferent arterioles of the kidney. The afferent arterioles before the glomerulus have got granular cells which secrete renin, and they have got beta-1 receptors, right? So sympathetic system or stimulation of sympathetic nervous system through those beta receptors will increase the secretion of renin, which will then go through all those conversions of angiotensinogen to angiotensin 1, angiotensin 2, aldosterone, and salt and water retention. Okay, remodeling, hypertrophy happens over there, cardiomyocyte death. So all of these things could happen as a result of sympathetic stimulation. So beta blockers are negative inotropes. So they slow down the heart rate, they improve systolic functioning, they reverse to some extent cardiac remodeling. And because they are negative inotropes, there may be transient worsening of symptoms initially. But, obviously you are not using beta blockers in acute decompensated heart failure. You are using them for chronic stable heart failure, all right? And the three that have proven reduction in mortality and morbidity are metoprolol, bisoprolol, and carvedilol. But I read somewhere that now penbutalol is also included in this category, all right? So that was, to address the sympathetic nervous system. We use beta blockers for renin-angiotensin, aldosterone. We use ACE inhibitors. And the next, again, we are still on beta blockers. So carvedilol is non-selective beta and alpha blocker. Alpha-1 can cause vasoconstriction, so alpha blockers are also vasodilators. Bisoprolol is selective beta-1, and so is metoprolol, okay? Beta blockade is recommended in all patients with heart failure, but contraindicated in acute decompensated heart failure. Start with low dose and up titrate. That's what we do for most of the drugs. And again, this graph has been obtained from a large clinical trial, and it shows that cumulative mortality is reduced with metoprolol. You see that it's much higher, about 16% or something like that with placebo. And with metoprolol, it is something like 8 or 9%. So mortality is decreased. So what we have done so far, we looked at the drug list and we looked at the goals. We looked at angiotensin converting enzymes, their indications and pharmacokinetics, their adverse effects. We looked at ARBS, their pharmacokinetics and adverse effects, and we looked at beta blockers, all right? Any questions so far? Okay, now let me see the time. I think we just have 5 more minutes, and I think we have got about 5 more minutes, okay? We started 3 minutes late, so we'll do 1 or 2 slides more, and then we will stop. There is a question for you. I'll let you read this question, and I'll let you answer this question. All right. Right. So I didn't get any answer. So it does not increase cardiac contractility. Okay, that's wonderful. I got a couple of answers which say C, okay? And I think that makes sense to me. And the answer, obviously, when you look at these signs and symptoms, the answer is C. You know, it does not increase cardiac contractility, reduction of angiotensin-mediated vasoconstriction in kidneys. That is correct, but that is not the reason for the therapeutic effect. All right, we are asking, why is it causing the therapeutic effect? Okay, so that is not the reason for the therapeutic effect. Stimulation of epinephrine release from adrenergic nerve. No, it doesn't do that. Stimulation of bradykinin metabolism. No, it doesn't do that. Okay, so the correct answer is C. All right, now we'll do this question and then we'll stop. All right. Now, in this question, you will have to tell me the drug and the reason for your answer. All right. Now, I'll give you the answer. I got one answer. Let me see, which is D, which is milrinone is not the correct answer, and this Arnie is not here. It's not over here. I'll tell you the answer right now. The answer is metoprolol. Okay, let me give you the answer first. Now, what do beta blockers do? They slow the heart rate. Now, remember, again, basic physiology. When the heart rate slows down, it is the diastolic time that increases mainly. The time of systole remains more or less the same. It increases very little. What basically increases in slow heart rate is the time of diastole. So when the diastole increases, we are giving more time to the heart to fill. So theoretically, it will not happen in all the cases where there is no space. Theoretically, when you give more time to the heart to fill, the cardiac filling will increase. And in case of diastolic heart failure, that will improve the signs and symptoms, right? So this means that basically because of the slowing of the heart rate, increase of the time of diastole, the heart will fill more than it was without beta blockers, and the end diastolic volume will increase. So theoretically, that is the answer, okay? So that is all. And next, we will not do today, we'll go tomorrow. Endothelins, which cause vasoconstriction, we will see how we deal with that, all right? So thank you very much for today. If there is any question, you can ask me. All right, so there is no question. Thank you very much. And I'll see you tomorrow at the same time. And I'll stop the recording here.